Down syndrome. Bache, let us start with our first main chromosomal abnormality. First main chromosomal abnormality in number, that is Downs. You already know it is trisomy 21. So you already know it is written as 47 XX or XY depending upon male or female plus 21. You know that. This is Downs. Now my question to you is pathogenesis. My question to you is, all of us, we have two chromosomes 21. One came from the mother, one came from father. That is normal. From where did this extra chromosome 21 come? Most commonly, that is in 95% cases, this is from mother or father, from the mother. This occurs due to maternal meiotic non-disjunction. This is from the mother. Maternal meiotic non-disjunction of chromosome 21. Maternal meiotic non-disjunction of chromosome 21. In the mother, during meiosis, N and N should have separated. In the mother, during meiosis, chromosome 21 did not separate. Non-disjunction of chromosome 21. So both chromosome 21 of the mother came, one of the father came, making this as trisomy 21 or Downs. Maternal meiotic non-disjunction of chromosome 21. Which is the main risk factor for Down syndrome? Main risk factor for Downs being increased age of the mother. Main risk factor of Down syndrome being increased age of the mother. Is age of the father important? Not for Downs. I guess it is certainly important for the mother, but age of the father is not important for Downs. Main risk factor for Downs being increased age of the mother, with markedly high risk being present above 35 years of age. Next point. So girls, say yes to guys more easily. Next point, especially we medicals, I guess. Next point. Major cause of Downs is maternal meiotic non-disjunction of chromosome 21. Next, it can be paternal non-disjunction also. It can be paternal non-disjunction. The father's chromosome 21 did not separate. Paternal non-disjunction also. Or it can be Robertsonian translocation. We'll be doing this in extensive detail in about 10 minutes, not to worry. Robertsonian translocation 1221. Robertsonian translocation. That is translocation, my mistake, 1421. We will see what we mean by Robertsonian translocation in 10 minutes. So, causes of Downs. If all of the above is given in the options, we'll mark that. Otherwise, the best answer is meiotic maternal non-disjunction of chromosome 21. Downs. Next point. So this gets us to antenatal screening of Down syndrome. That is, when the child is in the womb of the mother, antenatal screening of Down syndrome. Antenatal screening of Downs when the child is in the womb of the mother. We screen the child radiologically, in which we see for Downs increased nuchal fold thickness. I'm sure a lot of stress in this would have been read in obs-gynae as well as radio. Increased nuchal fold thickness seen in Downs. What is nuchal fold? It is the space between the perivertebral space and the subcutaneous tissue of skin of the neck. In simple words, increased nuchal fold thickness means abundant neck skin. In simple words, this is abundant. Increased nuchal fold thickness means abundant neck skin. Detected radiologically. Next, serologically, that is, we look at the presence of antibodies. Serologically, we do triple and quadruple screening for Downs. Serologically, triple screening, that is, we will look at 4 markers, and quadruple screening for Downs. Triple and the quadruple screening for Down syndrome. In triple screening, we look at 3 markers, that is beta HCG, beta human chorionic gonadotropin, beta HCG, AFP, alpha fetoprotein, AFP, alpha fetoprotein, and UE3, that is unconjugated estriol 3, UE3, that is unconjugated estriol 3. So triple screening of Downs. Triple screening, we look at 3 markers, beta HCG, AFP, and UE3. HCG increases in pregnancy, it is further increased in Downs. So beta HCG increases in Downs. Whereas very, very important, AFP, alpha fetoprotein, and UE3 reduces in Downs. Easy to remember. Beta HCG increases. See, in pregnancy, HCG is high. If it is markedly elevated, Down syndrome, beta HCG is increased in Downs. If it is going to the roof, it is very, very high. It is reaching the roof. In that case, what will we think of? That is, it is a malignancy. Beta HCG is a tumor marker of which ovarian tumor? Choriocarcinoma. We'll do it when we study ovarian tumors. Not to worry. AFP, again important. AFP is a tumor marker of HCC, liver cancer, hepatocellular carcinoma, and which ovarian tumor? Yolk sac tumor ovary. We'll write everything. We'll do it in female genital tract. Not to worry, just listen to this here. AFP is increased in liver cancer, HCC, and yolk sac tumor ovary. It is reduced in Downs. So HCG increases, AFP and UE3 reduces in Downs. Triple screening. And lastly is quadruple screening. We look at the 4th marker also. Quadruple screening, in which we add inhibin A. Inhibin A increases in Downs. Inhibin A, it increases in Downs. So in quadruple screening, 2 markers increase, 2 reduce. This is antenatal screening for Down syndrome. Next point. Down syndrome clinically. Down syndrome clinically. Acha, before we go further, have a look at this image. It is showing a child who is mentally retarded. Downs is the most common genetic cause of mental retardation, with abundant neck skin, increased nuchal fold thickness, abundant neck skin, epicanthic folds, and a flat facial profile. See, our face is contoured. Some elevations and depressions, so on, elevation of the nose, depression of the lips, and so on. Here the patient has a flat facial profile with a single transverse simian crease. This is Downs. See, the above 4 points are usually given in the question itself. Let us write this clinically. You already know it is the most common genetic cause of mental retardation. Downs, it is the most common genetic cause of mental retardation. Next point, the patient has abundant neck skin, increased nuchal fold thickness, abundant neck skin with epicanthic folds, with presence of epicanthic folds and flat facial profile. Epicanthic folds and flat facial profile. Facial profile is flat facial profile. Next, it is also associated with single transverse simian crease. Our hands, we have multiple lines. Down syndrome, it is associated with single transverse simian crease. These 2-3 points are given in the question itself. What the question is asked now are the other features of Downs. Down syndrome, bache, it is associated with CVS abnormalities. Very, very important. It is associated with CVS abnormalities. Most common CVS abnormalities seen in Downs. Most common being endocardial cushion defects. Most common CVS abnormality in Downs being endocardial cushion defects. Endocardial cushion defects followed by VSD, ventricular septal defects, followed by atrial septal defects. A common mistake that we as students make is we think that the most common is VSD, ventricular septal defect. Nahi bache. The most common CVS abnormality in Downs, is endocardial cushion defects, followed by VSD, followed by ASD. Next, Down syndrome. It is also associated with intestinal obstruction. It is also associated with intestinal obstruction. And where in the intestines, where is intestinal obstruction taking place? In the duodenum. Intestinal obstruction in duodenum. That is, it shows duodenal atresia. It is associated with duodenal atresia. Next point. There is increased gap. Let us see this in the image also. An image speaks 1,000 words. I mean, once you have a good look at this image, you will never forget this. Congenital heart defects, most common being endocardial cushion defect, followed by VSD and ASD. Intestinal stenosis, where? In duodenum. It is associated with duodenal atresia. Increased gap between first and the second toe, giving it the classical saddle toe deformity. Increased gap between first and the second toe. That is saddle toe deformity. Hypotonia. The tone of the muscles is reduced. Hypotonia. Umbilical hernia. Very, very important. Umbilical hernia is not seen in Turner syndrome. This is again asked. All are features of Turner syndrome except umbilical hernia. Umbilical hernia is a feature of Down syndrome and increased risk of blood cancers. So let's write this. Down syndrome. It is associated with intestinal obstruction. Increased gap. It is associated with intestinal obstruction. Next, increased gap between first and the second toe. Increased gap between first and the second toe. In turn, giving it saddle toe deformity. In turn, giving it saddle toe deformity. We have already seen that. Next, it is associated with hypotonia. It is associated with hypotonia. The tone of the muscles is reduced. Umbilical hernia, hypotonia. Umbilical hernia. Again, we have seen it is not a feature of Turner syndrome. It is a feature of Downs. And lastly, increased risk of leukemias. Lastly, Down syndrome. It is associated with increased risk of leukemias, increased risk of blood cancers. Which is the most common leukemia associated with Downs? But you think before you answer this. Most common leukemia associated with Down syndrome. We'll do this again when we study blood cancers or oncohemat. But first tell me this. Most common leukemia associated with Downs. Most common leukemia with Downs is AML M3, M5, M7, या ALL. Most common leukemia with Downs, ALL. Acute lymphoblastic leukemia, which do not go wrong in this at all. Most common leukemia in Downs is ALL, acute lymphoblastic leukemia. Whereas most common AML in Downs is AML M7. See, we'll do the FAB classification of AML in blood cancers. we'll see that it is divided into M0 to M7. Last number is M7. So least common AML is M7. But it is the most common AML in Downs. AML M7. Also called as acute megakaryocytic leukemia. M7. M7. Also called as acute megakaryocytic leukemia. So most common leukemia in Downs is ALL, but most common AML in Downs is AML M7. First class. But this was our first main chromosomal abnormality in number, that is Down syndrome, trisomy 21.